Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Your host, Dr. George Netto, is the editor-in-chief of Modern Pathology and the chair of pathology at the University of Alabama at Birmingham. Here's Dr. Netto.
Hello, everyone. My guest today is Dr. Arjen Cleven. Arjen joins us all the way from the Netherlands, where he serves as a faculty at the University Medical Center in Groningen and in the Leiden University Medical Center too. Arjen is an expert in bone and soft tissue pathology and a contributor to the latest edition of the WHO on the topic. We will be discussing his group's recent superb publication on SATB2 Rearrangement in Psammomatoid Ossifying Fibromas. There'll be a lot of terminologies, bone terminologies thrown at you today, so get ready. Thank you, Dr. Cleven, for accepting my invitation.
Yeah, thank you also very much for giving me this opportunity to give a little bit more details and backgrounds about the article. I think it's really nice to have this exposure and also maybe for other bone and soft tissue pathologists to maybe send cases also maybe to the group in the Netherlands so we can even learn more about this very rare tumor, I think. So to give a little bit of background about this whole study. So in the Netherlands, we are quite well organized in bone and soft tissue. That means that for the bone tumors, we have every month a multidisciplinary meeting. And that means that all bone tumors in the Netherlands are discussed there together with oncologists, with a radiologist and a pathologist. And I'm also a member of that committee together with other professionals in the bone soft tissue field. And what is really still the day life problem with these fibro-osseous lesions in the jaw, so also Psammomatoid Ossifying Fibroma, is that these bone tumors in the maxillofacial bones, they are difficult. I think they're difficult for radiologists and also difficult for pathologists because they're so lookalike on microscopy, and there are not that many molecular markers that you can do that you can use to differentiate between them. You have several molecular backgrounds to use as a diagnostic tool, for example, gene alpha mutation detection for fibrous dysplasia, or you may, for example, determine amnion tumorification if you consider low-grade osteosarcoma, but then there's a whole bunch of very rare entities in that location that you may consider, but without any immunohistochemistry, without any molecular diagnostic. So I think that was really frustrating in a way as a pathologist if you look at these entities in a way that you often give differential diagnosis, and then by time maybe the case becomes more malignant, or indeed it will spontaneously regress, but it was in a way uncomfortable by doing that kind of diagnostic. So that was really...
So hence you wanted to see what's so special about the Psammomatoid Ossifying Fibroma from a molecular aspect, right?
Yeah, so there was, of course, if you look back in the older papers on, and they use different terminology. They did not call them Psammomatoid Ossifying Fibroma. They were called more group-like osseous lesions, and they were grouped together with also osseous lesions outside the maxillofacial bone. But there were the paper by Parham a long time ago. He described two typical cases, I think, in the maxillofacial bone, and he did conventional cytogenetics, and he described a balanced translocation between chromosome X and 2 without knowing which genes are involved. But that was like a clear coordinates to look for. So there were evidence that there was a balanced translocation involved, and what we believe now at that time were Psammomatoid Ossifying Fibroma. So I think that was the idea to start doing gene fusion analysis with RNA transcriptomics and frozen material of the PsOFs. And then we indeed found the involved genes.
Okay, so to summarize in terms of background, these are lesions, there's multiple similar lesions. On morphology and radiology, still they're difficult to decipher. And in this particular lesion, the Psammomatoid Ossifying Fibroma, Other people have found XQ26 and 2Q35, I believe. Genetic cytogenetic exchange, and you were trying to zoom in. And so you mentioned already the technique you use is RNA-seq to identify the gene fusion. So how many cases you did, and how did you confirm the fusion once you found it?
Yeah, so the whole key for this paper was frozen material, right? If you want to do like genome-wide assays, then you need frozen material. So we had a really close collaboration with some clinicians, and then we got frozen tissue. And then for two, because it's a rare entity also in the Netherlands, so we were able to include 2 cases with fresh frozen tissue that we had clear-cut the diagnosis from, okay, this must be based on radiology, morphology, PsOF. So then we got the frozen material, and we did RNA-seq on those 2 index cases of Psammomatoid Ossifying Fibroma. So then we found a convincing fusion of SATB2 with the AL51 gene in one of those 2 cases, and then we of course RT-PCR, so we could sequence the chimeric protein, and that came out as a true new fusion. And then we collected several PsOF and also mimicking case of PsOF of paraffin, which we could perform FISH for SATB2. And so then you have an indirect, more on paraffin material. You can check for the SATB2 split, and that's indicative for also involvement of the SATB2 fusion. But and you can do that on cases that are not fresh tissue.
Excellent.
And then we were able to actually show in quite some cases that there was a recurrent finding of a SATB2 split.
And we'll come to the details of that in a second. So, but just to summarize again, so despite this being a very rare tumor, you had 26 cases of Psammomatoid Ossifying Fibromas that you had, I guess, paraffin, and a couple of them you had frozen, as you mentioned. And then you added, compare them to 8 cases of juvenile I have to look at my note, trabecular ossifying fibromas and cemento ossifying fibromas, also additional 11 cases. So a very extensive study for such rare entities. And so you went ahead on the paraffin and started using the FISH and the immunohistochemistry for SATB. And it seems it's not a straightforward negative positive. It's more like distribution. So can you help our audience, if they were to use immunohistochemistry, how to differentiate these things?
Yeah, so to make a small comment on the case, I think that the whole paper shows really teamwork in terms of you have an ID, but you need the clinicians, you need smart people in the lab, and you need also many cases. So we could. So the whole study was performed in the lab of Professor Dr. Judith Bouvet with a lot of infrastructure. You could do difficult assays, and then we had a really nice collaboration with Daniel Baumur. So he collected many cases from his archive in Basel. So that's really teamwork. So then to come back to FISH and immunohistochemistry, so you're right. I mean, the SATB2 FISH in the cases that worked were quite straightforward. It was, of course, we did many cases, and at least half of them did fail because of decalcification. But the cases that were okay for FISH, that was clear cut, easy to find a split. If you then want to link it to what's happening on the functional level of SATB2, if there's a split, so we could predict that it would lose SATB2, that the translocation would lead to a degradation of the protein. And what you then see, and that you see in many bone tumors with a driver, is that not, in the microscope, it looks like all the cells are lesional, but then at the end, we know that in most of these lesions, only few of the cells that you see in the microscope have the driver. So that's, I think, also the case in PsOF. And of course, that difference between tumors, but it was in a way heterogeneous, that also in a SATB2 FISH, some cells had a clear split and other cells didn't show the split. And then if you correlate it with the protein level, you saw in the cells without the split, you saw SATB2 expression, and the cells having the SATB2 split losing the expression. And that's also reflected on protein level and using immunohistochemistry. It's quite heterogeneous, that you see positive cells, you see negative cells, and sometimes that's difficult in terms of it looks very positive, and of course a few cells, and then to say based on a protein based on the SATB2 antibody to say whether there's a SATB2 rearrangement or not. I think that's difficult. So you can't use it as a real surrogate marker straightforward for saying, okay, we see a clear-cut pattern, and that's so this must be a PsOF. There are cases that are very with internal control, very negative for SATB2, and then in the right clinical context and morphology, it's helpful in saying, okay, this must be a PsOF based on radiology, microscopy, and the SATB2 immunohistochemic expression, and then not using FISH. But that, if you go back to the data we have, I think we could show it in, I think, 4 of the 8 cases that showed a split on SATB2 that really show clear-cut loss of the SATB2 protein. It was almost negative, or less than 5% showed expression. So in those cases, it's very nice.
So it is that marker I was wanting you to discuss. So it has to be in some of the cells, and usually there's the spindle cells, right? The lesional cells, and less than 5% of these cells were staining. You consider that loss of SATB2 expression, and maybe at least those cases you can flip to FISH and show that using split apart probes show that there is a rearrangement.
Yeah, and we also showed it on fluorescence in situ hybridization that indeed the cells. So we did parallel. So we did first on the same slide the fluorescence site hybridization for the SATB2 protein, and on the same slide we performed SATB2 FISH. So we could correlate the same cell FISH with fluorescence expression of SATB2, and then we really saw that the cells with the split didn't show SATB2 expression.
But the other lesions in the differential that we mentioned, those had expression in more. Yeah.
So in a mosaic way, so more than 25% of the cells, if you want to make it quantitative, which pathologists are always doing, semi-quantitative, but there were none of these mimickers of PsOF did show less than 5%. So there is a kind of pattern of SATB2 expression, and I think less than 5% of cells that express it doesn't fit with the mimickers, and it's more in direction of a PsOF,
But anytime this is the case, it really takes away a lot from the utility of using immunohistochemistry, because you have to have really only rare expression, and you don't know these are decal sections. So really, probably the message should be that you need to do FISH if you're thinking this is a Psammomatoid Ossifying Fibroma to show the SATB.
Yeah, I fully agree. And I think also, apart from doing immunos or molecular stuff, I think it's really important to do it in an expert multidisciplinary setting. I think PsOF is one of the examples of fibrous-osseous bone tumor that location that's not in a way that difficult. But I've seen osseous sarcomas that really mimic it. So you could, that's the whole point. Instead of having a lot of molecular tools, I think the whole multidisciplinary setting should be an expert center for this kind of lesions. So
you beat me to it, because reading the paper, and I meant it when I said it's superb publication, and that's the quality of papers that we love to have in our journal, and it's published, I think came out just January of this year. It's really an indication of teamwork, molecular, a lot of multidisciplinary work, multi-institutional, which is always very strong points for any study. But I was wondering, some of these are a little more destructive by location, and these particular lesions are benign. And I was wondering why does it matter this much? But I think you just hit on that. On a small biopsy, sometimes the differential will include some osteosarcoma. Yeah. So can you say what's your approach for our audience? What's a helpful practical approach when you're getting biopsies on lesions like that, especially in a young person in the orbital or maxillary bone and mandible and what have you?
Yeah, so I think so. At the end, you need with all kind of, especially the bone pathology, you need good radiology, right? you get lost at a pathologist without a good radiological differential diagnosis. I think that's number one, what's really important to have. And then if you go back to the tissue you receive with a nice differential diagnosis of radiology, you should, of course, I think it's difficult. And on the other way around, you can also argue that if you go back to the maxillofacial bones, if you talk about malignant lesions, osteosarcomas, they have they are more often in patients that are 40 years old. That means if you have a girl or a male patient of 10 years old, it's not that likely there will be an osteosarcoma. So although maybe if you doubt based on microscopy, including the clinical setting, it's very unlikely. On the other hand, for patients 40 years old that have a more higher chance of having osteosarcoma at that location, also, and that's why juvenile was taken out of the name in the WHO, can also occur at that age. So an older patient, I think, above 30 years old, I think there you should be really careful not to misdiagnose an osteosarcoma. And I think, like I say, you need really good radiology and by people that are experienced in those tumors at location, because the tumors at that location, if you talk about the radiological features of ossifying fibromas, are really different if you compare it to bone tumors outside the maxillofacial bone. So if you're not exposed to that kind of lesions, you have no idea what your DD should be on radiology. And then you also get lost as a pathologist.
Amazing. It's
getting
of course, so specialized, so subspecialized. So now even location.
I think
be an expert in that location too.
I think that's really what intrigues me. That currently we're also writing a review on the development of maxillofacial bones and then trying to find parallels in the pathways involved in the maxillofacial bone development compared to outside that location, and then to find parallels what is going wrong with pathways in a disease. So if we could link developmental important pathways with the etiology of the disease at that particular location, then maybe we can understand more the etiology of the disease. Because I really believe, of course, fibrosis dysplasia happens all kind of bones, but I think ossifying fibroma, the Psammomatoid Ossifying Fibroma variant, I think it only occurs in the maxillofacial bones, and that's because the development of that bone is different compared to all the other bones. So in terms of being specialized at particular bone localization, that's nice, but you also should have exposure to, of course, bone tumors at other locations. But I think for the maxillofacial bone, which is formed by endosmal ossification, is really different compared to other bones that are formed by endogonal ossification. So I think, radiology microscopy is different to what you expect, for example, in the femur.
Correct.
And if you're not aware of that, you make it yourself very difficult having a DD for a radiologist, but also for a pathologist.
Excellent. Thank you very much. Really, it was a pleasure discussing this paper, and hopefully our audience enjoyed it as much as I did and learned a few things on the way. Appreciate your support to the journal, and keep such great studies coming from you and your collaborator. You mentioned Dan Baumhauer, who's been a previous guest. So very prolific group in Switzerland and Netherlands. So we appreciate the exposure and the transatlantic contributions. So thank you very much, Arjen.
You also thank you very much. And I think my main message is that this is really teamwork, and I'm very grateful that I could work in the lab of Professor Judith Bouvet, and I'm having such a nice collaboration with Daniel Baumur and people like Karoli Shahai, smart people that bring ideas into a good paper. So I'm really very happy that I met those people and still working with them.
How great! Very to be very inclusive and give everyone a credit. I wish we could list every authors, but I refer the audience to the manuscript with some amazing microphotographs. Thank you very much.
Okay, thank you.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Springer Nature, UAB, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. Producers are Christina Crow, Amber Jackson, Dr. Sarah Jang, and Dr. Catherine Ketchum. Technical direction is provided by Kaminsky Productions, music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.